Somebody said C, daptomycin. Okay. We will see the answer in the end of the presentation, but meropenem is the very wide spectrum. We will see does it cover MRSA or no. We will see in the next in the coming slides. So this is the question number 2. Which of the following antimicrobial? Samir, there is any way to avoid the people coming on the screen? Because once people enter to the screen, it cover my slide. Samir, are you there?
You can change in the settings. There is a small settings icon. Remove all the notifications.
Where it is sitting? My
Bottom
setting?
right corner, there is a click the arrow, then there is settings
Okay.
icon. Then notification settings there, right?
Yes.
Uncheck all of them.
Okay. Okay, but the PowerPoint point gun.
No problem. I will put it back.
Okay. So question number 2. This is we'll go back here. Okay, so this is finished. Question number 2. Which of the following antimicrobial may cover Pseudomonas aeruginosa? Okay, so most of the people say C. So, wow, somebody said B. Okay, we'll see. Last question. Which of the following antimicrobial will not cover ESBL E. coli? Can you answer, please? There is chance for more than one answer, by the way. See, any answer? ABC. Somebody said ABC. CF, C, C and F. Okay, we will see that. Thank you very much. So, first of all, I want you to differentiate between gram-positive and gram-negative. This is very important. And I know here there is a lot of microbiology people from microbiology background. They know better than me. But I want just to tell you two messages. Number one, message number 1 is the peptidoglycan layer between the gram-positive and gram-negative. Example of gram-positive is Staphylococcus aureus, and the example of gram-negative E. coli. So you can see that here there is thick layer of peptidoglycan compared with thin layer of peptidoglycan in gram-negative. That's why gram stain with the gram-positive it will show purple color, while in E. coli it will show pink color, because when you wash the violet color, it is washable in gram-negative, while it's not washable in gram-positive. That's why it will stay violet, while in E. coli it will become pink. This is one of the key concept of gram staining, and it will help in the stewardship, at least in the beginning, because before when you start the treatment and you take the culture itself, it will take few days to appear. But by gram staining, you can have some hint. Maybe you will not cover, for example, gram positive if it came gram negative bacteria only. So this is message number 1. Message number 2, gram negative bacteria is hard to treat compared with gram positive. The reason why, this is because of the phospholipid. There is 2 layers, one inner and one outside. So the peptidoglycan is between sandwich, as a sandwich. So this prevents antibiotic to enter to the gram negative. That's why gram negative bacteria is hard to treat compared with gram positive. So this is the 2 concepts I want you to be aware about them. Here you can see the classification of bacteria. There is thousands of bacteria, but the pathogenic bacteria only few. This is an example of gram-positive bacteria, and here one example is Staphylococcus aureus. And Staphylococcus aureus, there is 2 types. One is the good one, or at least easy to treat, MSSA, methicillin sensitive Staphylococcus aureus, and bad to treat, very difficult to treat, MRSA, methicillin resistant. If we said methicillin resistant, means this is one of penicillin. We will test it in the lab. If it's methicillin resistant, it means it's resistant to almost all beta-lactam, except maybe there is a new one generation it's working, but all beta-lactam almost is not working for MRSA. When we are talking about gram-negative, the most important 3 bacteria, especially for hospital-acquired infection, we have E. coli. We have also, E. coli, Klebsiella, and Pseudomonas aeruginosa. Pseudomonas aeruginosa, it is resistant by nature. Only few antibiotic is working on it. Klebsiella, there is, I mean, different stage of resistance. The easy one, it will, the easy Klebsiella pneumonia, you can treat it even with ceftriaxone, but if it's became ESBL, all the ceftriaxone will not work on it, and the first, second, third generation will not work on ESBL, and even Cefepime will not work. In this case, maybe ertapenem and meropenem will work on it. Then the higher stage of resistance, if it start to produce KBC, even meropenem will not work on this. So the bacteria will learn how to resist to antibiotic, and now there is a new classification of antibiotic which is working. Let me make the slide bigger for me because I cannot really see the slide. 1 minute, sorry. When we are talking about atypical organism, the problem with the atypical organism, they don't have cell wall. So if we are, if it's a typical organism, the antibiotic which working on the cell wall will not work on them. So we have to use some antibiotic which will work on them, like azithromycin or levofloxacin or doxycycline. Because if you use any beta-lactam which work on the cell wall, it will not work. That's why when we are treating community-acquired pneumonia, we need to add to ceftriaxone, for example, azithromycin or doxycycline to cover atypical organism. Anaerobe, on the other hand, there is different type of anaerobe. Some of them under gram-positive, and some of them under gram-negative. And the one under gram-negative will behave like gram-negative, and the one under gram-positive will behave like gram-positive. We will come to see the antibiotic which cover them in next slides. So how the bacteria will make resistant to antibiotic? Maybe it will prevent entry from to the cell, or it kick it out like ciprofloxacin pseudomonas. If cipro enter, the influx, it will increase efflux pump and it will kick it outside. Also the target site of modification, for example, Staphylococcus aureus, when they will change the protein binding site, it will not, the beta-lactam will not work. That's why we need, for example, vancomycin in this case. On the other hand, there is a third mechanism here by inhibition, antibiotic inactivation. For example, enzymes like penicillase. You know, Staphylococcus aureus, penicillin initially when it was discovered by Alexander, it was working on Staphylococcus, but soon it learned how to make resistant by developing penicillase. So penicillin will not work Staphylococcus aureus anymore. That's why we need to add clavulanic acid to it if the mechanism of resistance is penicillin. But if the resistance is by binding, changing the target site of modification in the protein binding site, none of the beta-lactam will work on MRSA. This slide it look like very complicated, but I will make it easy to you, inshallah. So generally speaking, there is 3 mechanisms of action of antibiotic, either on the cell wall, protein synthesis, or DNA and RNA. This is the main 3 mechanisms. Forget about the others. There is another mechanism, but this is the main 3 mechanisms. Maybe 60% of the medication of antibiotic or antimicrobial is under cell wall, which we are using currently because they are relatively safe compared with, for example, aminoglycoside, which is on protein. We have also doxycycline and tetracycline on the protein itself. And within the cell wall, we have 4 categories, or we have 2 categories, either beta-lactam or non-beta-lactam. Under beta-lactam, we have 4 groups. Number 1, penicillins. And within penicillins, we can see narrow spectrum, wide spectrum, and someone which covers Pseudomonas like tazocine, which is piperacillin tazobactam. On the other hand, the cephalosporins, we have 5th generation currently. First generation, second, third, fourth, and fifth, and the gram-positive coverage will be high in the first generation and low in first generation. And as you increase in the generation, the gram-negative will increase, and the gram-positive will be reduced gradually as you are going in the higher generation. Which one covers Pseudomonas from cephalosporins? Only ceftazidime from 3rd generation, that's it. And from 4th generation, cefepime. So until now, we have 3 agents from beta-lactam, which is piperacillin, ceftazidime, and cefepime. When we go to carbaminims, 4 agent, all of them will cover Pseudomonas except ertapenem will not cover Pseudomonas, and all of them will cover ASPL, E. coli or Klebsiella. And under monobactam, we have only Astronam, which covers Pseudomonas but not cover ESPL. Okay, and when we go to fluoroquinolones, or which will work on DNA gyrase, we have fluoroquinolones. Remember that moxifloxacin will not cover Pseudomonas, but Cipro and Levo will do that. Aminoglycoside will cover Pseudomonas. When we talk about MRSA, none of beta-lactam will cover MRSA except softralone, which is new generation, will cover MRSA. This is the only beta-lactam. It's new generation, newly added in the market. And by mentioning the new product in the market, we have ceftalazone tazobactam and ceftazidime avibactam. Both will cover Pseudomonas and will cover ESPL, Klebsiella, and also E. coli, but will not cover MRSA, by the way. Only ceftralone will cover MRSA from all the beta-lactam. So meropenem, although it's very broad spectrum, still will not cover MRSA. On the other hand, if we want to know more, daptomycin also will cover MRSA. Of course, vancomycin, clindamycin, Ciptrin may cover, and clindamycin also may cover, but not 100%. So the answer will be in the culture. But there is a chance it can cover, not resistant fully yet. This is a slide is very important. I'll spend more time on it, and I need you to even take capture for this, and you can use it anytime. So this is the gram-positive and gram-negative up bacteria, and down the antibiotics. So if you, for example, if we took Pseudomonas and we go down all the way here, you see it's not covered. The Pseudomonas is not covered by a lot of antibiotic. Here only gentamicin and tobramycin. Here we can see ciprofloxacin, Astronam. But when we go to moxifloxacin, there is a space. It means it's not covered by moxifloxacin. And if we go to 1st generation, 2nd generation is not covered. And 3rd generation, we have ceftazidime, but not ceftriaxone. In 4th generation, we have cefepime, and we have piperacillin and ticarcillin, but we don't have ticarcillin in our market. Meropenem, impenem, it cover, but not ertapenem. Tigacil, although it's very wide spectrum, but still it will not cover Pseudomonas. On the other hand, if we go to gram-positive bacteria, and we have MRSA and MSSA, we can see in MRSA we have only limited option. Clindamycin is there, Rifampicin is there, but not alone. We will use it in combination. We have vancomycin, we have teicoplanin, linezolid, and daptomycin. We have ciptrin, which is cotrimoxazole, and maybe gentamicin will cover, and that's it. And also tigasil down. But you see meropenem, ertapenem, all with tazocine, none of the beta-lactam will cover MRSA. On the other hand, MSSA, we have many options. And you can use this table very, very efficiently if you study it well. You can see, for example, in an anaerobe, there is different bacteroid, and in bacteroid is you can see what is active against it, and also in Enterococcus. So I hope you understand this one, and you can take a capture, and I'm ready also to send you the slides if you wish, and use this very efficiently. It will help you a lot. But this is prediction. The truth will be informed by the culture. So maybe after the culture you will get it. It will tell you, no, already the bacteria is resistant to the antibiotic. So when the prescriber order antibiotic, he should balance between two things. The first one is to assure effective treatment for patient with the infection, and the second one is to minimize collateral harm for antimicrobial use, both antimicrobial resistant and Clostridium difficile, and the side effect of antibiotic, like for example, QT prolongation, C. difficile, diarrhea, etc., and fungal infection, super infection, etc. Because if you overuse antibiotic, it will lead to all these side effects. And on the long-term resistant, we know it may lead to there's a report, I don't have the slide for that one. In 2050, the death from resistance is more than accident and more than oncology together. So when you are using antibiotic, we are using it for three purposes: either prophylaxis, empirical, or definitive. For definitive, there is no much problem, so, because you have the culture and you have the sensitivity, but you have to select it wisely based on the site of infection, based on the type of patient you are treating. You have to have more data about pharmacokinetic and pharmacodynamic, and to select according to the indication. For definitive, no. For prophylaxis also, there is no much issue because there is a clear guideline. Use the minimum antibiotic, the broader, the short, or the narrow spectrum antibiotic possible. Use it the right time with the right dose. For example, drug of choice is cefazolin for most of the surgery. You have to give it in the right time according to the weight of the patient. If he's less than 120, it's 2 grams, but if he's more than 120 kilo, it's 3 grams within 1 hour of the surgery, and you add metronidazole to it if you want to cover anaerobe. And if the patient is allergic, you need to maybe give vancomycin or clindamycin according to the system you are doing the surgery. And if the patient have MRSA, vancomycin is the option. Again, 1 gram or 1.5 gram based on the weight if he's more than 90 or less than 90. So the major problem when the people selecting empirical treatment, this is I want to try to tackle in the remaining 10-15 minutes. So what is the optimal antimicrobial? You need to select the right dose for the right option, the right choice drug for the right dose with the right duration, with the right route. You need to think about time dependent and concentration dependent. You need to think about pharmacokinetic and pharmacodynamic. You need to think of vancomycin and aminoglycoside monitoring and take levels because it's nephrotoxic, for example. And when we are saying the duration, you have to use the shortest possible duration to avoid resistance for the patient and for the next patient. So which empirical antimicrobial you have to select? You have to do your homework. You have to do the diagnostic workup needed, X-ray, blood work, whatever needed to recognize to have a differential diagnosis. And therapeutic, you need to take a therapeutic decision, and you need to educate the patient and take history. History key, important, and to try to find the source of infection from the beginning. Then after that, you start the empirical based on informed decision. I will show you some systematic thinking in the next slide. And after 3 days, you need to rethink again and take the decision based on the new available information. So this is the model by I took this one from WHO, and we will take example for CAP, community acquired pneumonia. So generally speaking, you need to think about severity of infection. Is the patient critically ill or stable? If it's critically ill, you need to think about to give the antibiotic as soon as possible, and the route maybe you need to give it IV oral again based on the severity and spectrum. If the patient is critically ill and he's dying, maybe you need to give more wide spectrum, but wide in a wise way that cover the really needed organism, not necessary to be very wide, but the wide enough. Then source of infection. This is very important. You need to think about likely source of infection, because if you know the example, if you think about urine source, you think about E. coli. If you think about skin, you will think about staphylococcus or gram-positive bacteria, etc. So if you know the source, you know your target. And also, if you know the source, you can control it. For example, if you have intra-abdominal infection without, if you give antibiotic without control this by surgery, or the antibiotic will not benefit much. Then third point is to think about drug resistant. How? Main point is to think about recent antimicrobial use, especially IV, because the highest risk for having MDR is to have IV within 90 days. If the patient take antibiotic within 90 days, especially IV, he's at risk of multi-drug resistant. We will show you in other slides. And also, very importantly, you need to know more about your cumulative antibiogram. I will show you what we mean by antibiogram in another slide. And patient factor like allergy, renal, liver disease, if pregnant lady, if lactating woman, etc. So you need to take patient factor in consideration, elderly patient and kidney function, etc. Then culture, you need to try your best to take culture before start antibiotic, because if you took the culture and after 3 days you know the organism, you will know your target. Otherwise, you are working blindly and you don't know if you are covering the organism or not. So the best practice is to take culture before antibiotic, unless patient is very critically ill and you cannot do that. So we have here example of CAP. CAP means community acquired pneumonia. So patient came from community. Why we are differentiating between community acquired pneumonia, hospital acquired pneumonia? Because the organism causing community is different from organism causing hospital acquired. Usually hospital acquired infection or pneumonia in general, it's caused by resistant organism, more resistant organism, like Pseudomonas, gram-negative like Pseudomonas, like E. coli, sometimes ASPL E. coli, Klebsiella, or even MRSA. But gram-positive is a different community-acquired infection, is a different organism. So this patient, 45-year-old female with 2 days history of fever and chest pain, vaccine history not up to date, fever 39, oxygen saturation 91%, and there is bilateral rales and egophony. You need to do your differential diagnosis. You need to think about bacterial or viral, typical or atypical. That's why atypical coverage is needed for CAP. And here the guideline, either beta-lactam plus macrolide. Now we know why we are adding macrolide. Macrolide is added to cover atypical organism. Atypical organism is our organism without cell wall. So if you give ceftriaxone, it will not work because there is no cell wall, simply. Fluoroquinolone also will cover atypical and other organisms. So we I need you to know about a score. It's called CARE 65. This is a score would help you to decide whether to treat the patient outpatient, inpatient, or ICU based on the score. The higher score, the more critical patient and the high death risk. So you need to treat the patient in ICU if he's scoring 4 or above. I think from 4, 3, 4, and 5. So our patient score 2. when we did him CARB 65 score because of the calculator. So severity, based on the severity of disease, we will try to treat the patient inpatient, not in ICU, in normal ward. The differential was community-acquired pneumonia, and the organism, maybe because of the source of infection, most likely streptococcus pneumonia based off the history, vaccination, etc. So if we think about the drug resistant, the patient did not have take antibiotic, no history antibiotic, recent history, and local antibiogram, you need to take it. I will show you antibiogram, what we mean in another slide. And patient factor, no allergy, renal normal, not pregnant, culture, we took the culture, and we will start empirical antibiotics, ceftriaxone plus azithromycin based on the guideline, based on the differential diagnosis. And after 3 days, when we reassessed the patient was clinically improved. His culture became streptococcus pneumonia, sensitive one. We de-escalation. So this is one of the principles of stewardship, de-escalation from higher broader spectrum to narrow spectrum. Even from ceftriaxone to amoxicillin, it's called also de-escalation. Sometimes patient on meropenem will de-escalate to ertapenem or ceftriaxone. So escalation is and also we can think about oral. If the patient is stable, this is again from IV to oral is another principle of stewardship program. So let us shift now to hospital-acquired infection. So we think about community-acquired, now hospital-acquired infection. We have HAP and VAB. HAP, hospital-acquired pneumonia. VAB, ventilator-associated pneumonia. So the most important point to decide if it's this pneumonia, if there is a new lung infiltrate with evidence of infection, the evidence of infection, either fever, purulent sputum, leukocytosis, and the oxygen saturation. If this happened, but after 2 days, after 48 hours, this is called hospital acquired. But if it's only 1 day from admission, still it's CAP. Okay, and there is the other condition, no infection present at time of hospitalization. This is HAP, hospital pneumonia. On the other hand, VAB, this is one patient in ICU, and we intubate him, and he developed pneumonia after intubation by more than 48 hours. If it's 1 day, again, it's either CAP if he is recently admitted, or HAP if he is admitted longer than this. I hope it's clear. So risk factor for MDR resistant pathogen, what we have to give. We have to think about risk factor of MDR. I have maybe 5 more minutes. Okay,
yes,
so
please. Yes.
So for HAP, we will think and for MRSA and Pseudomonas if there is a risk factor for IV antibiotic within 90 days. So this is the most important factor. If we took history from the patient and we discover he took, for example, ciprofloxacin 1 month before, so he have risk of MRSA and risk for VAP. On the other hand, this is for HAP. Sorry, for VAP. There is more risk factor. Number one, the same antibiotic within 90 days. Number two, the patient got septic shock at diagnosis. Number two, if patient hospital length of stay 5 days or more, acute renal replacement therapy prior to diagnosis. Treatment strategy, antibiogram recommendation, hospital regularly generate disseminated local antibiogram. Antibiogram develop, you can make specific to disease, you can make specific to unit, you can make and you should update it routinely. And if you don't have antibiogram, you can use the national antibiogram. So I took this from Dr. Jens. Dr. Jens, are you there? Okay, so this is, I took it from Dr. Jens, 2018 UAE antibiogram. You can see this is for gram negative. You can see for example, actually the slide is very small for me. I will look it from other computer. Give me just a second. Yeah, So if we go to Klebsiella, let me see where E. coli, and here E. coli and venom. It's 69. So what is antibiogram? Antibiogram is a table of your antibiotic and bacteria in last year, and you need to calculate the isolates and see how percentage of sensitivity. So if you have, for example, 90% or 80% and above sensitivity, this means you can use it empirically. If it's less than 80, you cannot use it empirically alone. So you need to use it in combination. This is the concept of antibiogram. You can make antibiogram for the country, you can make it for the hospital, you can make it for a unit, you can make it for a system. For example, you want to make only urinary isolate antibiogram. So if you are treating urinary tract, you know what to give. For example, sputum or respiratory system, you can also do that. If you have high number of organisms, at least 30 organisms, at least 30 isolate without repetition in your time. You can do it 1 year or 6 months according to your number of isolate. And there's a program is called WhoNet. It can help you to do that. This is for gram positive. So for VAB, if recommendation to include coverage of staphylococcus aureus and the other gram negative, indication for MRSA coverage if you have antibiogram 10 to 20. This is the importance of antibiogram. So if you look to this in your antibiogram and it is more than 10 to 20 resistant, means less than 80 sensitive, you have to cover MRSA. This is one example. And other example, for Pseudomonas here, if you have less than 10, you need to treat with 1 antibiotic. But if it's more than 2, you need to cover with 2 antibiotic. If the Pseudomonas isolate are resistant more than 10, so 2 antibiotic you needed to guarantee that you are covering. That's why we are adding sometimes 2 anti-Pseudomonas to cover until the sensitivity came if we have antibiogram. But if we don't have, we will consider it's more than that. I will okay, and this is the last 2 slides. ASP core element 7, and the most important one I believe is leadership support from all the department, head of pharmacy, head of microbiology, head of medical, head of quality. It needs head of the CEO. If there is a leadership support, or the other core element will come automatically. There is different way. Either you may use the restriction before the prescription, or you may use the audit and feedback. You let the prescriber prescribe, and next day do audit and make education. Each one have its pros and cons. In our hospital, we are using mix of both of them, and de-escalation, duration of therapy, educational guideline, IV to oral, and dose optimization. All this is some principles. Last slide. This is the in the guideline, and our national guideline, the latest. Avoid unnecessary use of antibiotic when not indicated. And I'm done. Thank you very much. And just I will answer the questions here. Which one of the following antimicrobial will not cover MRSA? All of them may cover except meropenem. And here, which of the following antimicrobial may cover Pseudomonas aeruginosa? Ceftriaxone will not cover, ertapenem will not cover, moxifloxacin will not cover, but Cipro and Levo will cover, Tigasil will not cover, so it is Tazocin. And this is the only penicillin will cover. And then from 3rd generation, we have Ceftazidime will cover, and Cefepime will cover from 4th generation, and meropenem, emambenem, and will cover. Last question, which of the following antimicrobial will not cover ESBL E. coli? Okay, ertapenem will cover ESBL E. coli. Aztronam, no. Ceftazidime, no. Ceftazidime avibactam, yes. Meropenem, yes. Meropenem vaprobactam, yes. Ceftalazone tazobactam, yes. Piperacillin tazobactam, no. Which one will cover Pseudomonas and ESBL? Ertapenem will cover only ESBL, will not cover Pseudomonas. Astronam will cover Pseudomonas, but will not cover ESBL. Ceftazidim, that's it. This is. And I'm done. Thank you very much, and I hope you enjoy it. And if you have any question, I'm ready.
Yes, thank
you very
Dr.
much.
Saeed.
Thank you, yes, Dr. Saeed, for this beautiful presentation. And if the attendees would not mind, we shall leave the question and answer to the end of this session. However, Dr. Saeed, I'd like to thank you for the interesting way you have presented your presentation, where you have started with a teaser of questions. Then you started talking about the gram-positive and gram-negative bacteria, leading us into different types of bacteria and antibiotics and how do they work out with the different bacteria, ending up with the stewardship program and what do you mean by antimicrobial stewardship program. Finally, I like the idea that you started with a teaser of a question and by the end of the lecture or your presentation, you have already answered and gave us the answers for the antibiotics which are working with different bacteria. Thank you so much, Mr. Saeed and Dr. Saeed, and I like please just to repeat that we shall postpone the question and answers to the end of the second presentation in order we can have a comprehensive idea and concept about the topic we were talking about. Allow me please to move now to our second guest, whose name is Dr. Saeed Alawadhi. Dr. Saeed Alawadhi, he was graduated from Bahrain from the Arabian Gulf University with distinction. After that, he went to the States and started internal medicine residency program and completed American board certificates. Dr. Hussein, he joined Harper Wayne State University in Detroit Medical Center, Critical Care and Pulmonary Fellowship Program, and his interest is in infectious disease. So he completed even a fellowship in infectious diseases. He is an American board certified in critical care and infectious diseases. He was previously working in Mufrag Hospital as chief of medical ICU and recently certified in American Board of Medical Quality. Dr. Saeed is currently working as consultant in infectious diseases and intensive care at Sheikh Khalifa Medical City in Ajman, and he has been invited as well in many local and international meetings to present about critical and infectious diseases topics. However, allow me, Dr. Saeed, I want to add just one more statement to your introduction, is that yesterday I had the pleasure to talk the first time with Dr. Saeed, although we had shared some sessions, but we didn't talk directly. Yesterday, I discovered another point with Dr. Saeed, which is 180 degrees contrary to what I have introduced you to him. Dr. Saeed, he is already Dr. Saeed, he's already interested as well. In addition to the medicine, he's already interested in Arabic literature and history as well. I remember I had 5 minutes of discussion or talking with Dr. Saeed yesterday. We were talking about Sha'r al-Jahili and the old times in the past. However, we are going to shift back the 180 degrees. We'll go back to the medicine if you don't mind at all. Dr. Saeed, the floor is yours, and you are most welcome to start your presentation. Thank you very much.
Shukran, Doctor. Thank you very much. Can I have my slides so I can start?
Saeed, yes, Samir.
Okay. Yes, I have my slide. I will put my timer. Start. Bismillah ar-Rahman. Thank you, Professor. In Arabic, those who used to fight in the front, they used to call them Adi. Adi means the one who fight in the front, the enemy. That's so you are a front fighter. That's the meaning of your name. So you have to be very proud of your name. That's the meaning of your name. Okay, so I will talk about a bacterial infection in COVID-19. What we learned so far, I think we learned a lot. I think maybe earlier no, but I think we learned a lot. So let's see what I learned. So first thing I learned today morning that July the 1st is a National Doctor Day. This is, by the way, this is new to me. So I never celebrated that Doctor National Day. So please celebrate and tell me congratulations. I never know about that. So today is the 1st of July and we're doing that presentation. In the United States, 1st of July is the day of the fellowship and training start. And usually the mortality is higher than that rate because new team are joining the program. The other good thing today that in United Arab Emirates, the mosque and other place of worship will start to reopen from today. So this is something good news that we are going back to our normal community. So this is two information 1st of July. So I have a lot of education objectives. I will just read it for you to review bacterial infection, resistant patterns. So we'll skip it. An important part I'd like to stress that a patient will be happier and better if there's a good relationship between the physician and a pharmacist, because we as a doctor, we write drug. These drug cause side effect. We do a lot of drug interaction. We don't adjust according to liver or renal functions. So having a pharmacist with us is really, really good for the patient, number one. So if you work with a clinical pharmacist, you should be proud of that. If you don't, please hire one or send him to any university to have a master or PhD in clinical pharmacy. So let's start what we know so far about previous viral infection. So this we know, when you have an influenza virus infection, you will have secondary bacterial infection like Streptococcus pneumonia, like H. influenza, like Staph aureus. So if you have a viral influenza pneumonia, and if you want to add empirical antibiotic coverage, we can say maybe you are right because of these data. And there's another data about H1N1. This is from 2018. So a review. And in these studies, they found 20% of H1N1 influenza, they had strep pneumonia, 1 out of 5, which is quite high. So if you have a pneumonia, viral pneumonia, and there's a chance 1 out of 5 later down the road they will get pneumonia and they may die, and you say I will hit it hard from beginning, you may have justification. So that concept of principle of viral pneumonia having a secondary bacterial infection is based on other viruses. And this is another study, by the way, with patient with bacterial pneumonia. So they have a bacterial pneumonia presented with bacterial, and we found all these with bacterial pneumonia, 20% of them, they have also a viral infection. We don't know which one started first, but again, this is old data, okay, from 2017. This is another data, viral infection in community-acquired pneumonia, systemic review and meta-analysis 2016, again 25%. So there is 20 to 25% of bacteria and virus together will attack you or your patient. This is the previous data. What about the corona? So during the initial corona news, January to March, the internet was full of news, some true, some false, and who cares? Whatever it was written in the internet, people start to believe. Okay, so look here. Sorry. COVID-19 patient needs to be tested for bacteria and fungi, not just the coronavirus. Many, who said many? But it was the internet. Everybody's writing whatever they like in the internet. Many hospitalized victims are developing potentially lethal secondary co-infection, such as bacterial pneumonia and sepsis. This is April 2020. Okay. And this is a blog, Scientific American blog. Okay, they write in this 50% they have secondary infection. This is serious information. They're telling you viral pneumonia, okay, coronavirus, 50% of them, and they give you a reference, okay, and they will get reference, but nobody read the reference, okay, and I put the reference. This is the reference, but if you read the reference, it doesn't say like that. Okay, it says old age, sepsis tied to poor COVID-19 death. They did not say bacterial infection, but what happens in the WhatsApp news, okay, or internet, or Instagram, or Facebook, or Twitter. Co-infection, potentially lethal and unexplored. They did not say co-infection definitely lethal. They didn't say it explored, it's known, but the way people rewrite it and put that reference that bacterial infection is common. So let's see what publication shows, actual publication shows. So this is one of the initial publication. This is initially from Wuhan. This is the Wuhan mark, 200 cases. So this is the initial publication, and this is something fresh. So they just collected 200 patient data. Sorry, the number is covered, but this is 200 patient. Is the number is here, okay? And they look here. 97% of them, they received antibiotic, and I don't blame them. They were hit with viral infection. They says influenza has a lot of infection. This is new virus lit through antibiotic plus everything. So 97% of cases received antibiotic, and this is initial data. They did not report any true infection. This is another data. Rates of co-infection between SARS-CoV-2, which is the COVID-19, as Professor Adi mentioned at the beginning, and so this is in California. 1,200 patients came to the ER with viral symptoms. Out of 1,200, 10% they had COVID, 90% COVID negative. Out of 10%, which is 116 patients had COVID, none of them tested for bacterial co-infection. So they tested them specifically for bacterial. None of them had bacterial co-infection. Nosocomial infection among patients with coronavirus 2019, a retrospective analysis of 918 cases from single center in Wuhan. Out of 918, they reported 7% has bacterial infection. 7%. Now, look carefully. The 7%, some were pneumonia, some were bacteremia, some were UTI. So the UTI, it's not part of the bacterial infection to the lung. It's because of your Foley catheter. The bacteremia is not part of the viral infection of the lung. It's because of central line. And they proved that in a retrospective review. And they look to the what causes infection. If you have a central line, if you have diabetes, and if you add the antibiotic to your patient, they're more likely to get UTI or CLABSI. And the infection rate was 2%. So out of 918, 2% had bacterial infection. This is another study, okay? This is initial publication. This was 813. And again, 95% of this patient received antibiotic, very high. I don't blame them. They were just hit with a virus. And at that time, if you remember, when initial news came from China, nothing was mentioned about other things that we'll speak about now. So all received antibiotic. And because they receive antibiotic, it doesn't mean they have infection. They don't have bacterial infection. And in that study, they wrote half of patients developed sepsis. Be careful. Sepsis could be viral sepsis. Sepsis means hypotension. Sepsis means high lactic acid. Sepsis doesn't mean by default bacteria. Parasite can cause sepsis. Fungus can cause sepsis. Virus can cause it. In these cases, nothing mentioned about what bacteria isolated. And those who had a secondary infection, it happened late on day 17. You can see here day 17 in the graph down, secondary infection, but they didn't report and they died. Of course, this patient in ICU, on ventilator, down the road, if you go to ICU for a long time, they did not develop secondary infection here that you need to cover them with antibiotic. This is another study. Again, this all descriptive study. In these cases, 99 cases, you can see 71% of them received antibiotic. Only 1% of them, they had proven bacterial infection. But everybody's throwing antibiotic, not only in China, even here, everywhere. So conclusion from that study, the antibiotic rate was high, but infection rate was very less. And when you give antibiotic at the beginning, and after 7 days you do a culture, it will be negative. That's even useless. And they did not do culture. Clinical feature of patient infected 19 in Wuhan, China. And again, this is another series. And in that series, This is 41 cases. Out of 41, 4 only developed secondary infection, which is 10%. But this is 40 cases, nothing. And nothing mentioned what bacteria isolated. Again, this is 1,099 patients from, again, in China. You can see the names, Hong, Bong, Yong, Kong, all Chinese name. I can't read them. I can't read them. I'm sure when they read our names, Mohammed, Abdullah, and Ahmad, and Adi, and Husain, and Saeed, they will make fun of us. So I'm just mentioning. So these all, because why? All the initial publication was from China. And again, 1,099 patients. And in these publication, majority, 60%, 2/3 received antibiotic. Okay. But again, nothing was mentioned about bacterial super infection or what organism. When you don't mention what bacteria, I will assume you don't have bacterial super infection. This is another series, 138 cases. 2/3 of them received antibiotic. Nothing mentioned about bacterial super infection. They mentioned liver function, renal function, chest X-ray, D-dimer, ferritin, all the things I mentioned. Because our talk today, if there is evidence of bacterial super infection to be high rate, the answer is no. And then, so knowing all of that, by that time, which was April and March, then we start to discover new information. The whole concept that when you have a bacterial super infection, that's killing your patient. So if you give antibiotic, strong antibiotic at the beginning, big one, strong one, broad spectrum coverage at the beginning, empirical. Dr. Saeed mentioned empirical and prophylactic antibiotic and different antibiotic. He mentioned that clearly. You may prevent the patient from dying. By that time, by March and April, we discovered new information from European by the disease that those who have a viral pneumonia, when they deteriorate and they die, something else happens in between. What's that? What we call the cytokine storm. Okay, cytokine storm. That is what's killing your patient. That's number one. And the second, and these are all the inflammatory mediators. Okay, antibiotic does not kill, does not eliminate, does not remove inflammatory mediators. Number two, what we learn, these people developing clotting, thrombosis. So that's what's killing you. By that, we have to be careful, and people start to be worried. COVID-19 may worsen antibiotic-resistant crisis. Of course, when we threw all this antibiotic, so the virus is very happy. This is killing and destroying all the antibiotic. It takes years to come with a new antibiotic product. It takes years to formulate a new antibiotic and change its chemistry to make a difference. And virus will take care of that immediately. So COVID-19, a message from the CEO of the British Society of Antimicrobial Chemotherapy. They say this is very alarming. We will expect soon to have bacterial resistance. Why? Because antibiotic is used broad spectrum, tazocine, meropenem, cipro, levofloxacin, widely, and this is not right. And there's a lot of discussion. So this viral pneumonia, it's causing bacterial resistance. So, sorry. So what we should do to wisely use antibiotic, we have to differentiate bacteria from infection. And we have some guidance, by the way. So this is from University of Oxford, Center of Evidence-Based Medicine. And you can go to that website and it will give you some guidance how you differentiate viral from bacterial pneumonia. And it says clearly, do not offer antibiotic for the treatment or prevention of pneumonia if COVID-19 and mild. Don't give antibiotic, clearly stated. And if you want to give, start with oral, doxycycline, amoxicillin. Don't start tazocine, meropenem, all these big guns. Bacterial and fungal co-infection in individual with coronavirus, and this is in May 2020. So they reviewed all the different coronaviruses. And the conclusion, it's only 8%. So it's not high. There's no justification now. You remember the initial Chinese? They gave to 90%, 80%. I can say they didn't know, they were hit hard. But now we learned from them. Why? In our world, go back to your hospital, to your ICU 2 weeks ago, to your ward. Look how many patients you have out of 10 or 20 are on antibiotic. It is only 8% have proven infection. So recommendation, I'm telling you, can consult infectious disease expert, could be an ID or clinical pharmacist. Please do microbiological sampling. Just don't throw the antibiotic. Do a sputum culture, urine culture, and everything. This is a recent nice review in May 2020, recognition and management of respiratory co-infection and secondary bacterial pneumonia in patients with COVID-19. Very nicely written, by the way, very simple and nicely written. And it gives you what helps you to diagnose bacterial infection. And procrastination is important, but what I've seen personally, many patients have pure cytokine syndrome with high procrastinin, and they respond to steroid and they do not respond to antibiotic. This is something we have to be aware of. And so it's very important. You do not throw the antibiotic in patient with a COVID pneumonia. Why? I'm repeating the message. All the current literature and publication did not show significant antibiotic, a significant bacterial overgrowth. And later, which is last 2 months, we learned that the major cause of deterioration is the cytokine syndrome. They will not be better with antibiotic, or the thrombosis and clotting, and they will not be better with antibiotic. This is a nice also, COVID-19. Don't neglect antimicrobial stewardship principle. I am not going to do this talk now. This is beyond today's objectives. This was mentioned by my previous speaker, okay? But you should not forget, you should re-establish your stewardship program. This is very, very important. And I'll just show you one reference. Sorry. So by now, what happens? We use a lot of antibiotic. Bacteria are happy. And virus is happy, coronavirus. Coronavirus say, I fooled you. I made the bacteria happy. Why? Because they're developing resistance. And we use a lot of antibiotic and lose money. So we need to go back to the balance. The amount of bacteria, it should be equal the amount of antibiotic. We cannot have 97, 95, 90% of patients on antibiotic while only 10% have a true infection. This is my last few slides. Those who are interested, this is written before Corona, exactly a year ago. Principle and practice of antibiotic stewardship in the ICU. And the first item, it says, consult with ID doctor and a pharmacist. Don't throw antibiotic. And when the patient is very sick, you'll say, let me call the ID doctor. If you do not have an ID doctor, talk to your pharmacist. If you don't have a pharmacist, you have a microbiologist. Don't tell me that in your hospital don't have a microbiologist. And if you don't have an ID doctor, clinical pharmacist, you learn from coronavirus. You need them. Your patient needs them. The antibiotic needs them. So this is very, very important. So I say today is the Physician Day, but I will not forget that soon, September 25th, is the World Pharmacist Day. So probably that day we'll celebrate, and I hope by that time we sit together. No social distancing will be in a party. Say amen, all of you. Okay, if you invite me, I will come. And I think this is my last slide. Questions? Yes, please. I think I'm done. So I'll stop here. I took 20 minutes. So, and thank you very much.
Thank you. Thank you very much, dear Dr. Hussein. And allow me, please, before I make my input on your kind presentation, is that Dr. Hussein, your name should definitely not be confused. Actually, I was confused when I started to introduce you to the audience. Apologies about my introduction. I was thinking about your background experience and your upcoming talk to an extent where I mixed up names between you and Saeed. So apologies, Dr. Hussein Alawadhi, onto this.
Saeed means happy. It's a nice name. And
This is a
Saeed,
good point.
his father or grandfather is Hussein, so it's okay. It's all accepted.
Thank you so much for your kindness onto this. Thank you, Dr. Hussein. Actually, I totally agree on your kind of presentation, where many of the people are confusing between viral and bacterial infection. Many people who are working on health profession, they offer antibiotics for people who are infected with the viruses. So again, as you said, there is a big difference between bacterial or superbacteria infection and viral infection. So with all my due respect to the work of the physicians in general, whom we truly admire and appreciate their kind work, but we have always to refer as well, in addition to the physician, to, in general, the pharmacist, and specifically to the clinical pharmacist. One more point, Hussein, is that I liked that your presentation was accompanied with the latest literature review. And this is absolutely, this is the scientific way where you can convince all the people that what we are talking about is not about our personal judgment onto the issue of antimicrobial stewardship, but rather this is the general norm, and this is the correct scientific action against or upon dealing with viruses and bacteria. Ladies and gentlemen, allow me now to introduce our smiley friend who's smiling. I can see his beautiful smile on the screen, Dr. Imad Makramullah. Dr. Imad Makramullah, he's a clinical pharmacist as well at Zaid Hospital with special interest in ID and cardiology. Dr. Imad, he was graduated from the Azi University in 1999 in Egypt, and he received master's degree in clinical by Supreme Council of Universities, Cairo University, in 2014. Dr. Imad Makramullah, he is a board certified pharmacotherapist and board certified cardiologist as well. Cardiology pharmacist, I mean. He participated in many publications in the field of polypharmacy and brand versus generic area, which is a very important topic nowadays when we are talking about dispensing and prescription drugs, prescribing drugs. He presented at many national and international pharmacy conferences. Dr. Imad بدنا نغلبك معنا. Dr. Imad, he has been kindly watching all your chats on the side screen where he collected all the questions, and I shall leave the floor for you, Dr. Imad. Thank you so much in advance for your kind efforts.
Thank you very much, Doctor. I have two questions for Dr. Saeed now. The first question, the two questions by Dr. Shamza. About the name of the program used in antibiogram. What's the, Dr. Saeed, are you with me?
Yes.
She's asking about the name of the program.
Can you hear me?
Yeah.
Okay, Dr. Shamza, Dr. Shamza, the one who was with our hospital. I hope you are the one, inshallah. Anyway, the answer to your question, the program is called HUNIT, and I already sent you a link for that program. It's free program. It's used more than 30 years in more than 2,000 hospitals around the world. It's free of charge, used, and it's supported by WHO. You can download it, and it can take the data from a Phytic machine, or from if you have system, Cerner system or Epic system, it can take the data by support of your IT, and it can also you can analyze it, and it will help you a lot instead of doing it manually, which is very, very difficult, and it needs a lot of people to do that. But this program will take a report in 1 year, and you can do it very, very easily. HUNIT, and you can go Google it and search for YouTube to how to use it. I prefer microbiologist to work on it. Otherwise, clinical pharmacist or a doctor who's interested to do that. Thank you for your nice question.
The second question by Dr. Shanza also about the 10% of isolates for antibiotics. She wants to elaborate more on this point. And I think if I understand the question about the one or dual anti-zoonotic agent, single and dual anti-zoonotic agents, when to use each of them.
Okay, so this is again nice question. Okay, think about antibiogram. Okay, assume you did the HUNIT program and you did last 2019 Pseudomonas in the ICU, and you did antibiogram for that one, and you found, for example, 100 Pseudomonas in your ICU. This Pseudomonas was 92% sensitive. So you start empirically with 92% sensitive to tazocine. So you can start tazocine and you will feel happy because the chance for success is 92%. So that's good. No need to double coverage. On the other hand, if you again in ICU and you got only 60% of tazocine sensitive to Pseudomonas, means 40% resistant. It means you cannot start empirically with tazocine alone. You have to add maybe Cipro or gentamicin to have a high chance to cover the organism, because the chance for fail is high. So in case the resistance is less than 10 is okay, but if it's more than 10, you need to double coverage. I hope I answer. It's clear.
Yes. The next question is for Dr. Hussein. The role of procalcitonin in differentiating viral and bacterial infection, and it has a second part. Does it increase the procalcitonin test? Does it raise with fungal infection?
Thank you very much. Let me give you a follow-up answer to the previous question. Do not use double anti-Pseudomonas coverage. If you want to do that, talk to your consultant first, or talk to an ID first. There's rare occasion that you need a double Pseudomonas coverage. That's a classical old teaching in the school, medical school, and most of the scientific guidelines do not give, unless you have a true neutropenia and with rare occasion. So in general, don't give your patient double anti-Pseudomonas coverage. I hope that answered the question. That's number one. Number two, procalcitonin talk. I love procalcitonin. I use it, but I use it properly. In non-COVID patient, people use procalcitonin. On day 2 and 3, procalcitonin is normal, and they will continue antibiotic. I said, let's finish 7 days. This is wrong. Procalcitonin, if you are not going to change your management, this is very common, because you start antibiotic today, you say the culture will take 4 or 5 days, and you do procalcitonin today, it's normal. Then you wait next day, it's normal, but you continue the antibiotic. So don't use procalcitonin. If you're going to continue antibiotic, then you're wasting the antibiotic and wasting the money of the patient insurance or the hospital by ordering procalcitonin. It's 100 dirham almost. So don't. Now, COVID, we learn new things in them. We learn they have clotting, thrombosis. I never heard in my life that a bacterial infection will cause a major thrombosis. So what we're learning, I said we're learning that in COVID patient, I noticed many of them have high procalcitonin without evidence of infection. So if you have raised inflammatory marker and or your culture are negative, I will not escalate the antibiotic. I hope I answered the question. This is a hot topic. It needs one session discussion about biomarker in COVID.
And the second part, does it have a value in fungal infection?
All the previous literature for last 10 years, it says almost majority means 98% of fungal infection, they don't raise the procrastination level. Okay, they don't raise. But we'll make an exception. I'll give you an example. If you have a bone marrow transplant, if you have a kidney transplant, okay, and they are at risk of fungal infection, high risk. This is very specific, okay? A friend, he's heavily immunosuppressed, and you order procalcitonin, and their procalcitonin level on the low. They are at risk on the fungal infection, or the procalcitonin is high. I will not say this is pure bacteria. I will not do antifungal because procalcitonin is not raised in fungal infection. So in these specific cases, I will give antifungal, although rarely it is raised in fungal infection. I'll repeat the message. So you have high procalcitonin. I will say this is bacteria in regular patient. So in regular patient, I will discontinue my antifungal therapy. I will not start antifungal therapy. I will stop antifungal therapy. I will de-escalate. I hope I'm repeating this term so people practice it, okay? In a specific scenario, bone marrow transplant, neutropenia, organ transplant, high risk of fungal, I will say, no, this is a special case. I will continue antifungal until I prove it's negative.
Yes, thank you. I think no more questions from the audience, but I need your comment on something.
I have one comment myself before we close. I hope all hearing me. We internationally, بالإمارات, بالكويت, بالسعودية, بالخليج, يعني الحمد لله, all of us, we are seeing COVID disease is going down. I think all we notice that. Please take it serious. We are, maybe the public may not take it serious, but we are the medical community. We have to take it serious. We can have second head. That's important message I have to you. Number two, we know last 2 weeks, a lot of discussion about steroid, and I am pro-steroid. I started using the steroid before the recovery trial, and yesterday we had a seminar about it. When you give your patient steroid therapy, which is and everybody will get steroid, I mentioned at the beginning, watch your COVID patient for more chance of secondary bacterial infection. Clear? So yes, give your patient dexamethasone or methylprednisolone, but watch and observe. Don't give empirical antibiotic coverage. Watch and observe. 1. 2, when you give steroid, you will have leukocytosis. Don't react to leukocytosis and say, oh, I give a steroid, you became infected through antibiotics. So 2 message. Thank you.
Dr. Sorry for my interference, but I like to make a note that we have a significant figure with us in this webinar. I like to mention that we are honored to have Dr. Mariam Galidari, who's been with us since the start of this webinar. And we are privileged to have you, Dr. Mariam. You are famous to be known as the mother of pharmacists here in United Arab Emirates. Dr. Mariam Galidari, I wonder if you, it's our privilege, if you like just to add a couple of points. The floor is yours, please, Dr. Mariam. Thank you for being with us again, Dr. Mariam. Please.
Thank you, Doctor. Thank you. Alaikum wa rahmatullahi wa barakatuh. All, I would like to thank Dr. Hussein and Dr. Saeed on the valuable medical information presented by them. Then I would also like to thank Sheikh bin Mohammed Smart University for their cooperation with Emirates Medical Association Pharmacy Society. It is my pleasure to invite you all to join and be a member in this association, each in their specific field. We will provide to attendants with an e-certificate, which is essential for license renewal, hoping that all of you will be members in this association. Thank you, and may Allah grant us.
Thank you so much, Dear Dr. Mariam, thank you so much for your nice introduction. Thank you so much. We really appreciate it. Dr. Ahmad, please.
Yes, there is one more question for Dr. Saeed and Dr. Hussein about the antibiotic use in practice for ICU patients without history of MDR. I didn't figure out the question because it didn't give more details.
Yeah, this is for Dr. Hussein. It's saying what you will use for patient in ICU without history of MDR in your ICU setting.
سؤال مفتوح wide question. It depends. Do I have UTI? Do you have pneumonia? Do you have pyelonephritis? Do you have meningitis? Which patient you're talking about who's coming to me? If I have a pneumonia, I will focus on strep pneumonia. If I have a UTI, I will focus on E. coli. If I have an abdominal infection, I will focus on anaerobes. And so it depends. And there's always empirical UTI, empirical pneumonia, HAP, CAP, meningitis. So cellulitis, skin and soft tissue infection. So it's a wide question.
Yeah, she added one comment. It's for COVID patients.
For COVID patients, don't give antibiotic. Don't give antibiotic. Don't give antibiotic. Yeah. Monitor your patient. Give them oxygen. Give them antipyretic. There will be high white cell count. This is not bacteria. There will be high CRP. This is not bacteria. High ESR, not bacteria. It's not bacteria. And you will notice, all of you, if you work with COVID, their cough is dry. If they day 5 and 6, they said the cough is wet and it's green sputum, then yeah, they're having an infection. Then you can give ceftriaxone. We give in our hospital stewardship program only ceftriaxone at the beginning. That's it. We give ceftriaxone. That's the only thing we give at the beginning. We're in the ward before they land to ICU.
I need a comment from Dr. Hussein and Dr. Saeed also. Critically ill when we face as AMS pharmacist a patient in a critical situation and ICU doctors start anti-pseudomonal agents, the widest spectrum antibiotics. We don't have the gut after all these evidences to counsel them about stopping all antibiotics. It's
okay. It is 9:30, so you control the time. I know. It's 9:30, so you can control the time. So you can stop. We're out of time. I'll stop. It is a hospital duty to hire infectious disease doctor. It's a hospital duty to hire a clinical pharmacist, because people used to throw broad spectrum coverage forever. You cannot just suddenly change that concept. We cannot do that. Okay, how? By seminar, by activities. I'm sure many people listening to this program and conference, it's your job as a clinical pharmacist and the pharmacist to as part of education. It takes time to change the culture of people. So if you're a clinical pharmacist, a master in clinical pharmacy, you have a board, a PhD, you do a scientific talk with everything. That's the way the doctor will listen to you.
The problem is that I agree with you, Dr. Hussein, but you know, when it came to critical ill patient, as a stewardship members, sometimes we are scared if harm happen to the patient. It's due to the stewardship program. So really, sometimes it's challenging to decide. Sometimes patients, so sometimes we cannot intervene. So I don't know in this case what to do.
Stewardship program tonight, small webinar. Our talk is in the COVID. Prove to everyone in COVID you need to have a stewardship. No evidence. When your doctor tomorrow puts a broad spectrum antibiotic, you should talk loudly. You're qualified. You're trained. You have a certificate. Do not lock yourself down. You are part of the medical team as a pharmacist. You should say to the doctor, don't fight with him, but with a scientific evidence. Doctor, the evidence does not support that. But if you keep quiet and you have a training and certificate and master and PhD and you don't talk, what's the benefit? As I said, the first slide, who will benefit is the patient. So I know, because I work with many clinical pharmacists and they don't talk. I said, why didn't you say to the doctor, that's your certificate. You're allowed. I cannot fix that. You should be proud of yourself as a pharmacist. We need you. The patient needs you. But if you don't talk, this is your problem.
Yeah, but it's really challenging. The patient crashes despite best care given to him, and we stopped antibiotics. They can put us in the corner and put us in front of administration.
No. Wait. Again, stop the discussion if I'm running out of time. It cannot be like that. You need to make a friendship. You need to, with the hospital administration, CMO, make a committee between you as a pharmacy, microbiology, and a treating physician, and build up a hospital policy for certain antibiotic. Then the hospital is following the hospital policy. So what should be blamed is the hospital policy, not you. Is that clear? You need to have a protocol, for example, for management of UTI and COVID, what you should recommend. So the doctor should be stick with that policy. And if the patient crashed, the blame will go to that policy. It will not get blamed to you. So you need to work with your local team to build the policy. And that's why Dr. Saeed mentioned, you need the antibiogram. You need to work with that.
Very important point, Dr. Hussein. This is what I call pharmacotherapy workup team, which is composed of a group of members, and one of them should be the patient himself. This is what I call it, the empowerment of the patient in his treatment. Doctors, pharmacists, everyone in that group, they have to consult as well with the patient himself or herself to have into consideration his or her views onto the treatment. I truly salute you on this opinion and into the thinking of implementation and enforcement of this pharmacotherapy group in the hospital in general. Thank you. I truly appreciate that.
I have
There's a suggestion by Dr. Moses. If we are going to repeat this session again, she likes to invite a clinical microbiology specialist. Yeah, I think it's a good idea.
Dr. Moza Sharhan, she is the president of Emirates of Medical Association, for attending our session, and thank you for your support. And hopefully there is many of microbiologists attend our lecture today. Hopefully we can repeat it again in the near future with collaboration with their members, inshallah. Thank you very much. And there is a link, I send it for the certificate. I already sent it up. I will put it again, and you can fill the form. So we can send you the certificate if you are a member. And if you are not member, please become a member. To any there is more than 40 society. You can join in any society belong to you. Thank you very much.
Thank you, Dr. Saeed. And I believe the certificates will be sent within 2 weeks, right? Just to confirm the dates for the participant, it will be sent with the 2 CME credit hours within 2 weeks.
Yeah, but the certificate will be given only to the members, and who's not member, they can still be a member and get the certificate.
Exactly. Thank you very much. Mr. Dr. Ahmad, would you like to close the session?
No. For me, all questions are given already. No more. Thank you, Dr. Ali.
There is one more comment from, he said he want to collaborate with veterinary association, with animal, because animal health is also important because of misuse of antibiotic in animal. So inshallah, we can do that, inshallah. Thank you.
Thank you so much.
Maybe the Hamdan Smart University can give discounted offer to people to join. Maybe, I don't know. Yani special price or discount.
We should consider including some of the learning resources management with us in the coming meetings. And I'm glad that Ms. Maryam Mohammed, she's with us, and I'm quite sure she will take care of that issue as well.
Yeah, because scientific knowledge based on scientific study is very important. And we have a valuable university like Hamdan, a Smart University, people, young generation. I'm the old generation, okay? So young generation.
No, come on, you're still young. Yeah. You are still young, Dr. Hussein, come on.
Yeah.
Dr. Arula Shaban, she is the president of of Emirates Veterinary Association. Thank you for attending with us today.
So I believe by this we are going to conclude, yeah?
يلا مع السلامة.
Thank you so much. Thank you so much, all of you. Thank you so much for your efforts. Thank you all. God bless.
And
مع
thanks to
السلامة.
our
مع
nice,
السلامة.
nice moderator behind the scene يعني.
Somebody asked how to be a member. Just go to EMA link.
Have a nice
EMA, search for EMA and Emirates Pharmacy Society Association, and you will find all the details. And if you go to the link of registration, also you can do that.
Is this lecture is videotape? Would it be on a YouTube on the?
Yeah, it will be registered. It will be registered, and they will send it to us, and we will send it to the YouTube, inshallah.
Okay, very good, very good. So make it a series from a specific university, MBRU or any place. I don't know. I'm not part of that part. So you decide who will take the credit. يلا مع السلامة.
Inshallah.
Where we look out? Where we look out, Mr. Samir?
I think